So what I'd like to do is give you a perspective from sort of the ground level where we work on regularly taking care of patients at the medical center. I was interested when Dr. King mentioned about the Surgeon General in 1967. I found this quote from Time magazine in 1966 that said, nearly all experts agree that by the year 2000 bacterial and viral diseases will have been wiped out. And we laugh about that, I think, but the reality is at that time the feeling was that antibiotics were being produced at high levels, new antibiotics were on the horizon. It looked like we were going to be very, very successful. When I was doing my training, there was still some of that attitude, and there was an article that came out that was called The Infectious Disease Consultant for Whom the Bell Tolls, and basically said, we're doing such a good job of managing infections that all the infectious disease doctors are going to just be sitting around in their offices culturing each other, so it was, but obviously because of resistance, that's not the case. So this was a early observation by microbiologists that recognized that microorganisms can respond to their environmental stimuli, particularly antibiotic pressure, and recognize that this may be an important thing in the future. And then over a decade ago, the CDC recognized that if we don't get a handle on antimicrobial resistance, that drug choices that we've been used regularly will become increasingly limited and expensive and sometimes non-existent. As Dr. Schlesinger mentioned earlier, we actually have Pseudomonas and Acinetobacter and other isolates in the hospital right now that are resistant to everything, and we are unable to treat them. So I presented this slide to you earlier, but this is a great article from Science that looks at the timeline that as we've introduced new antibiotics, it's only been a short period of time after introduction before resistance is recognized. And whether those genes were there to begin with or whether they're a result of mutations, I wouldn't disagree with anything Dr. Singer said. I think that there is a lot of data to support that the resistance genes have been around for a long time. But we do know, particularly when you look at evolution of beta-lactamase genes, that there has been a role of mutation and evolution in development of that resistance. But this looks at over time where we started out with just a simple penicillinase to the point where now we have these carbapenemases and extended spectrum beta-lactamases that in the gram-negative organisms. And I would also, I don't put the slides up, but I think would echo what's been said that we actually have done a pretty good job, maybe because MRSA has had such an impact that there's been a lot of pressure to create antibiotics against gram-positives, and we do have new MRSA drugs that are out. But in terms of the gram-negatives, which I think is my bigger fear, we have very few new drugs that are coming out for the treatment of these highly resistant gram-negatives. So this is kind of echoes what Dr. Singer was talking about. As you start with the population, certainly you can have horizontal gene transfer. We've seen that happen. There can be mutations that create new resistance mechanisms. But I think the biggest concern is that you have a population where there are some strains that have resistant genes, or their resistant strains are present, and when you expose them to antibiotics, you select for the resistant strains. So this is just from the human perspective, this is one way of looking at these. Lou Rice, who's at the Case Western, coined this term escape pathogens, which are a number of these organisms that tend to be resistant or can have inducible resistance. And my view is, I've kind of looked at, I think from just the sheer volume of patients that we take care of, we see more methicillin-resistant Staph aureus than probably any other pathogen. But the national data has shown that MRSA rates are actually going down. And we've actually seen that in the medical center, that we're having fewer, as far as our total percentage of Staph aureus isolates that are methicillin resistant has gone down. But we struggle a lot with these multi-drug resistant gram-negatives. And so we started out with ciprofloxacin resistance. Now we have inducible beta-lactamase resistance, extended spectrum beta-lactamases, and carbapenem resistance. And then really the last drug on the horizon, which we'll talk about in a minute, colistin, or one of the polymyxin drugs. We now have resistance to that as well. And then I'm not going to talk much about the vancomycin-resistant strains, but those, we see a lot of VRE and some of the others. And then we deal with a huge problem with Clostridium difficile infection, and there is this epidemic strain that's resistant to quinolones, and so it's been, because we have such a high use of fluoroquinolones for respiratory infections, it's helped to select for these resistant C. diff epidemic strains in the hospital. So one of the first challenges has been just, and I think Dr. Singer alluded to this a little bit, what's the definition for multi-drug resistant? The Institute of Medicine many years back said could be just resistant to one class of antimicrobial agent. And that really, if you only have resistance to one class, is that really multi-drug resistance? The CDC in previous recommendations in terms of managing from an infection control perspective said if you have a bacteria that's epidemiologically important to your healthcare setting, then that should be considered drug resistant. Or if it's a new isolate, the first time it's been introduced into your hospital or your healthcare setting, your nursing home or whatever, or it's increasing in frequency, then that's something that you should treat as a multi-drug resistant pathogen. But fortunately, just very recently, this Congress group of experts from both Europe and the Western Hemisphere got together and came up with some definitions. And I'm not going to go through this just to make you aware of this article if you weren't, but basically uses, MDR as multi-drug resistant, XDR as extensively drug resistant, and PDR as pan-drug resistant. And hopefully this shows up well, but basically multi-drug resistance is, I have to see if I can read this myself, isolate that's non-susceptible to greater than 3 or more agents in one, or 3 or more drug classes, whereas XDRs, you're susceptible to only one agent in less than 2 groups, and pan-drug resistant is resistant to all. So this has kind of given us a new definition in terms of that. And so they're, like for Staph aureus, if you go to this thing, you look in the table, and it has the drugs that we would normally use for treatment of Staph aureus, and if you have resistance, depending on which profile, you can determine whether you have a MDR or XDR or PDR isolate. So from our research perspective, as part of this talk was to look at surveillance and the impact on human populations. We've tried to take a different approach. Instead of just using standard sort of epidemiologic and risk factor outcome data, we've combined that with molecular typing, looked at clonal distributions of isolates, and also combined that with geographic linking and looking at clustering of cases, and also with social networking analysis, where you can link patients together from a social network that shows the risk of their transmission. And for the sake of what I wanted to present here for a minute, I'm not going to talk about all of these, but particularly just talk a little bit about some genotyping studies that maybe put a little bit different perspective on the way we think of populations of organisms. So let me talk a little bit about methicillin-resistant Staph aureus. So the anti-penicillinase antibiotics that were developed in the 1960s, particularly with methicillin being the prototype, it was recognized just even within 2 years of introduction of methicillin that there was methicillin resistance. And so we don't use methicillin anymore. We use nafcillin and oxacillin. But MRSA was shown to contain this mecA gene, which encodes for this modified penicillin-binding protein, which reduced the binding of methicillin, oxacillin, or nafcillin, and then rendered those have less susceptibility. And it's also resistant to cephalosporins. And the mecA gene is housed within what's called a staphylococcal chromosomal cassette, which also can house multiple resistance genes. So historically, on the human side at least, the MRSA was really found only in the healthcare settings, and most of the nosocomial or the healthcare-associated MRSA had lots of drug-resistant patterns. They had these very large SCCmec gene complexes that housed, as was mentioned in the last talk, multiple resistance genes. And usually the patients that had this had healthcare-associated risk factors. They'd been hospitalized, had a lot of antibiotic exposure, device exposure, been on hemodialysis in a nursing home, chronically open wounds, those kinds of things. And the healthcare-associated MRSA could cause infections at many different sites, in the lung, in the bloodstream, the skin, the urinary tract, and so forth. Well, about a decade ago, it was recognized that there's these increasing reports of patients getting MRSA in the community who had very little or no direct contact with the healthcare system. And they had a very different profile. Phenotypically, they didn't have all that multi-drug resistance. Their mecA gene cassette was much smaller than the ones in the hospital. And there was usually younger patients that were most often associated with skin and soft tissue infections, and not, infections other places. So we began to recognize there's these two different strains, if you will, of MRSA. So the hospital-acquired had the large mecA gene complexes, had multi-drug resistance, and if you did pulse field gel electrophoresis, they tended to have these, particularly USA 100 and 200 kinds of strains. Whereas the community-acquired had a much smaller mecA gene complex, was resistant only to the beta-lactam drugs. It was these young patients with skin and soft tissue infections, and usually had different pulse field gel types. So that's been kind of the state of the art for a while, and we do know that you get mixing. We have the hospital strains of MRSA that are out in the community, and there's been outbreaks in hospitals of community-acquired strains. In fact, there was a large population study in San Francisco where they found that there was an increasing tendency to have the community strains causing hospital-acquired infections, so they were moving into the hospital. So when we looked at MRSA, we had a project that was funded by the CDC. We wanted to actually characterize what's the risk for transmission of MRSA between hospitals. We were actually just asking the question, what's the risk for transmission of resistant pathogens between communities and between healthcare settings? We decided to use MRSA because it's so common. And we decided to look at the epidemiologic risk factors as far as characterizing patients based on whether they're healthcare associated or community associated based on their epidemiologic profile. We looked at genotyping with pulse field gel electrophoresis. We used a repetitive sequence PCR method, and then some sequence typing, SPA typing, and multi-locus sequence typing, and also characterized the mecA gene. So that was our genotyping methods we looked at. And then we did look at geographic distributions, and we're in the process of doing some social networking analysis. But I wanted to kind of focus on the genotyping issues, because I was pretty amazed that we think of MRSA as MRSA, but actually MRSA is this huge heterogeneous population of isolates that can have very different genetic profiles. So we had 7 hospitals here in Ohio that participated, and for about a year's period of time we collected all of their clinical MRSA isolates. So these are isolates from true infections. And we had this very simple schema for collecting data. So but basically, just simply the hospital, when they had an MRSA isolate, they would collect the isolate, they would enter it into a database system we had. They got a de-identified code. That's what they would send the isolate to us with this de-identified code. Our micro lab would do the genotyping. We've sent it to other labs for other additional typing. And then we collected about 270 pieces of clinical information on each patient and entered that into this large database that we've been able to analyze. And this is just, we had this web portal entry, so the infection control people at the hospital could enter the patient data. It would give them, where that blue thing says code assigned, as soon as they entered the data and pushed submitted, a number would magically appear. That was their de-identified code. So we were able to look retrospectively at about 450 isolates from the OSU Medical Center, and then we collected prospectively from OSU and from these outreach hospitals about 1,300 more isolates. So I want to just focus on one thing. So in the process of doing all this analysis, we came across this unusual strain of MLST type 239 strain of MRSA. And so among the 1,286 isolates we genotyped, 78 or only 6% of them sequenced out as this very unusual ST239, and it didn't fall into the typical USA 100 or 300 pulse-filled gel typing. And what we know about ST239 is it has a very strong history of successful dissemination in many regions of the world, but it's really not been reported in the United States. And it was associated with a 2-year outbreak in intensive care units in London. It's the predominant healthcare-associated strain of MRSA in China and Korea and parts of Asia. It's been highly associated with lung and central venous catheter infections. And the concerning thing is it's highly resistant just beyond methicillin, so it's resistant to clindamycin, trimethoprim sulfa, moxifloxacin, and gentamicin. So a lot of the drugs that we would normally use orally to treat MRSA, it's pretty much resistant to all of those. So we ended up doing a great deal of additional phenotyping or genotyping, and I'm not going to go through it, but this is just sort of a breakdown of all the clinical characteristics between the ST239 strains, the USA 100, USA 300 strains, and other strains that we have in this database. But the interesting thing is when we did looked at the phylogenetics of this isolate, it turned out that it is part of a clade of isolates that's is associated with a clade in China, and it's probably been based on the projection of the distinction between the different isolates. It's probably been in central Ohio maybe as long as 20 years ago. And the only reason I bring all this up is that I think we need, as we start looking at the surveillance of these drug-resistant isolates, we have to think beyond just doing the routine susceptibility testing. I think there's so much value that can be gained from looking at things from a molecular genotyping surveillance. And I think there's a whole evolving field of molecular epidemiology. So I would just kind of bring that to you, that as we go forward trying to characterize resistant strains, I think we can gain so much in understanding not only the epidemiology of where the isolates came from and how they were transmitted and so forth, but also in terms of understanding their role in disease. So as we've looked at the isolates that we have in this database, we find that certain strains are very associated with lung infection, some are highly associated with the catheter-related bloodstream infections, and they tend to produce high biofilm concentrations or capability compared to other strains. So I think there's a whole evolving field that can be applied to this. And so as we think about the surveillance in human populations and in animal populations, I think the molecular genotyping and epidemiology is going to be very important. So let me just go through a couple of other pathogens that we face on a regular basis that keep me awake at night, I guess, sometimes. So Pseudomonas aeruginosa, which was really a major pathogen in hospital-acquired infections in the 1970s, continues to be a persistent problem. It's a common environmental pathogen. It's a water pathogen, and it's been highly associated with pneumonias in hospitalized patients, particularly ventilator-associated pneumonias. It causes bloodstream infections. It's a major problem in patients that have cystic fibrosis, and can even cause hot tub folliculitis. So my wife gets mad at me because whenever we travel, I refuse to get in hot tubs. So for this and many other reasons, but anyway. But imipenem, this is just one example of, and we'll talk about carbapenem resistance in a moment. But this is a fairly old study, up to 2000 at the University of Pennsylvania, where they had noticed this steady increase in imipenem resistance. And when they did the epidemiologic study, they found that the major risk factor was prior fluoroquinolone use. And for some reason, in a lot of these epidemiologic studies, fluoroquinolones have been highly implicated. They've been implicated in MRSA, increased MRSA transmission, in C. Clostridium difficile acquisition, and then in this study as well. But what they found is these resistant infections resulted in much longer hospital stays and increased hospital costs, $81,000 per patient versus $48,000 for susceptible strains, and also had a significantly increased mortality rate. So this is one of the earlier studies that suggested we were going to have problems with increasing resistance among gram-negatives. We've seen an influx of extended spectrum beta-lactamase producing Klebsiella and E. coli particularly. We've also seen it in Proteus and Enterobacter as well. But I think probably, I don't even know if it's 10 years ago, maybe in 2005 or 4, only about 3 or 4% of our Klebsiella or E. coli had ESBL production, and now it's probably close to 15 to 20%. It's been a steady increase. And so these are plasmid-mediated enzymes that will hydrolyze all penicillins and cephalosporins essentially. So really the only choice we have is to use carbapenems. And so as we've had increasing carbapenem use, we've seen problems with that as well. And so this is just from one study, looked at what are the risk factors. And this is, the only reason I put this up is this is a pretty typical risk factor profile for almost all of the resistant gram-negative pathogens. Prolonged hospitalizations, antimicrobial exposure, catheters, devices, those kinds of things. So it's kind of a recurring theme. And sometimes as we read these studies, it's like it's just the same profile for almost every group. And then this is, I thought this was interesting. This is a little bit older study, but just looking at the, through this Century surveillance program, just looking at in some places here in Latin America, there's much higher prevalence of ESBLs than in the United States, although we're starting to catch up. And there seems to be these geographic differences. For example, ESBLs and carbapenemase producing gram-negatives, there's been, like in Israel, for example, there's been a huge problem there, and in Greece as well, more so than in the United States. So the carbapenemases, this is a group of enzymes that are able to inactivate many antibiotics, including those in the carbapenem class. So really, if you have a carbapenemase producer, you're not able to use cephalosporins, penicillins, or carbapenems, and we end up using colistin, which I'll talk about in a moment. But the KPC strain, the Klebsiella pneumoniae carbapenemase, or the KPC, has been the predominant one in the United States and elsewhere. And this is one of the early reports of this in an outbreak in a medical center in New York. And there was another outbreak shortly thereafter in 10 Brooklyn hospitals where there was transmission of these strains between the hospitals. And you can see they were susceptible to polymyxin B and colistin and tigecycline, which is a new tetracycline drug that we have, but was resistant to most other antibiotics. And then you probably remember the report about the New Delhi metallobeta-lactamase. So this is another carbapenemase enzyme that was first described, and I'll show you some of the data in India, but it's now been in almost probably close to 40 states within the United States, including we've had it here in Ohio as well. So this was one of the initial studies that came out from looking at India, Pakistan, and the United Kingdom. And they basically, if you show the number of carbapenemase producing strains, the blue is the NDM1, and you can see that dramatically increased between 2008 and 2009. But the other beta-lactam, or the other carbapenemase strains increased as well. And then this just showed the spots within India and Pakistan and also the United Kingdom where this had been distributed. And again, this is a strain that's been rapidly disseminating across the world. So it's just an example of, as these new resistance mechanisms get introduced into the healthcare system, it's pretty easy for them to be transferred globally, with the global travel and everything that we have. Last organism I wanted to just talk about briefly is Acinetobacter, which is a ubiquitous, encapsulated, aerobic, non-fermenting gram-negative. And I'm not sure if this is something you deal with in your world at all, but it's capable of causing both community and healthcare-associated infections, and involves the pulmonary system, urinary tract, bloodstream, and surgical wounds. And the interesting thing about these organisms is they have a high propensity to develop resistance. And so when we first started first started seeing Acinetobacter, almost all the isolates were pretty susceptible, but within 1 year, almost all of them that we've isolated have become resistant. So most of and that was like 7 or 8 years ago. So most of the strains we deal with in the hospital are highly resistant. And again, the same kinds of risk factors. The other thing is, this is an organism that tends to exist in the environment. And when we've done some study of isolates have shown that they do have these efflux pumps as one of their mechanism of resistance that allows them to not only be resistant to a wide range of antibiotics, but also resistant to the cleaning agents, the biocides that are used to clean quaternary ammonium compounds, for example. And so the organism can be ubiquitous in the environment, and which promotes more easy transmission. And so some of the early outbreaks, again, poor New York City, they had an outbreak in Brooklyn with 15 hospitals. And there was also another, this is just examples, another 4-hospital outbreak in Johannesburg, South Africa. So colistin, a drug that I guess many people thought had been put to rest many years ago, but it's a cyclic polypeptide, it's polycationic, and it's basically like a large detergent molecule that disrupts the cell membrane. And it's particularly active against Pseudomonas and Acinetobacter. And those are the two primary pathogens that we've had to use it against. It can be neurotoxic and toxic to the kidneys, and resistance occurs, but it's generally been felt to be rare. And then there's this report from a few years ago from Korea, where they had 48 isolates, of which 30% were resistant to colistin. And since that time, we've seen colistin resistance in our medical centers, and it's increasing reports of it around the United States as well. So I think that, the sequence, if you look at that Science article and go on, that seems like as soon as we introduce an antibiotic into the system, it's not very long before we see the resistance develop, and then we introduce a new antibiotic, resistance develops, and that's been kind of the sequence. And again, sort of which came first, the chicken or the egg, in terms of the genes or not, but certainly the antimicrobial pressure that is contributing to that. And that kind of goes back to what I was trying to talk about in the last talk, was just, one, we don't have very good metrics to know how much antibiotics are being used and how we're using them, and I think until we get a better system for monitoring that, we're not going to really be able to get our hands around it. But also, I think being much more aggressive about restricting use of antibiotics, the stewardship principles, that I mentioned, I think are going to be key to dealing with this. But this is just kind of a flavor for you of what organisms we deal with on a regular basis. And I think, so just going back to, MRSA is certainly there are these multi-drug resistant gram-negatives, even including extensively or highly or pan-drug resistant Acinetobacter and Pseudomonas. And then we do see a lot of problems with vancomycin resistant Enterococcus as well.